The opinions expressed are those of the host. The material is for informational purposes only. It does not constitute investment advice, and it is not intended as an endorsement for any specific investment. Visit crestmontpw.com for more details.
Welcome to the Ascent. This is Sam McGee, brought to you by Crestmont Private Wealth. We are a wealth management firm that is in Boerne, Texas, and Houston, Texas. Today, a little shout out to my mom on this one too. She was our number 2 fundraiser for the Avon Walk back in the day in Houston, Texas, where thousands of women would go and walk for breast cancer awareness. And that's kind of where I learned a little bit more about breast cancer and the importance of prevention and mammograms. And today we have a really special guest. We have Dr. Oscar Ochoa, who is a board-certified plastic and reconstructive surgeon specializing in advanced breast reconstruction techniques, including microsurgical procedures. He practices at PRMA Plastic Surgery Center in San Antonio and serves as the director of research. A little bit about his bio. He is an undergraduate in biomedical science from Texas A&M University. Whoop. And he has a Master of Science in Clinical Investigation from UT Health Science Center. He completed his residency in general surgery at UT Health Science Center, San Antonio, followed by a residency in plastic and reconstructive surgery at the University of Texas Health Science Center in Houston, Texas. And we're proud to have him on the show. Welcome.
Thank you, Sam. Thanks for having me. Appreciate it.
So in a wealth management context, there is a lot that goes into planning for healthcare and, looking at having the right insurance carrier and what kind of plan you're on for Medicare. And today we're going to talk about a specific gap in the insurance side of things with breast reconstructive surgery. And unbeknownst to me, previous to meeting Dr. Ochoa, the long-established procedure of breast reconstructive surgery is covered by insurance. And a lot of people don't know that. I didn't know that. And many people think of it as an elective surgery when it is actually covered by insurance, by this law. And Dr. Ochoa, please explain what that law is and how it relates to insurance reimbursement. Maybe just starting at the top on insurance reimbursement.
Right. Yeah, it's a complicated subject. The American medical system is complex. Some people say there's lots of inefficiencies in it. There's definitely a lot of room for growth. So I'm going to try to distill it down to a way that is easy to understand. From my perspective, some of the important points. The way that doctors and insurance carriers, including Medicare and Medicaid, the way they communicate is through use of something called CPT codes. It's kind of like a barcode on a grocery item. With that code, it basically says, this is the procedure I did. This is the complexity associated with the procedure, which is closely tied to an RVU, revenue value unit. A simple procedure has lower RVUs than a very long and complicated procedure. So very simple sort of scenario there. So we communicate using CPT codes. So there's something called a Healthcare Common Procedure Code system that the CPT code sort of is part of that. There are 2 levels of CPT codes. The level 1 is the one that the CPT codes, those are the ones that have already been established, well recognized. Nobody has any questions as to how much to get reimbursed regarding that code. Those codes have a definitive number of RVUs assigned to it, and everybody's happy.
So like an appendicitis kind of surgery or something like that?
Right, exactly. Okay. So for an appendicitis, you get your appendix out, the surgeon sends a bill to the insurance carrier saying, I performed the surgery, the code associated with that surgery, and then the surgeon will get reimbursed based on the RVUs. There is a second level of codes. These are sort of off the menu codes. These are for experimental, novel procedures, as well as some like random like supplies and services, like ambulance services, for example, are coded using a level 2 code, something that we never think about.
Mm-mm.
But in certain types of situations, when a novel procedure is developed, and there is no associated CPT code with it yet, they get assigned a new code, or we call an S code, for reconstruction surgery. And this DIEP flap that I mentioned earlier has an S code assigned to it. That tells the carrier that this is a newer type of procedure. The reimbursement on that is not set in stone. You can kind of negotiate with the insurance carrier, Medicare, Medicaid, as to how much should you get paid for that procedure. And as I alluded to earlier, it's an evolution, it's an advancement of the previous surgery, the previous procedure called the tram flap. The tram flap has its own designated CPT code. So the S code for the DIEP flap, it's a temporary code. Usually the life history of an S code is usually about 5 to maybe 10 years. The S code for the DIEP flap has been present for over 20 years. So it has long lived its normal existence. So back in 2022, CMS, the Center for Medicare and Medicaid, said, you know what, we're gonna reassign, we're gonna eliminate the S code for the DIEP flap. We're gonna just assign it the normal tram CPT code. And the reimbursement differences between the tram CPT code and the S code associated with the DIEP flap, night and day different. Because a tram flap can be done relatively fast. You're just removing the muscle, not dissecting the blood vessels out carefully. You're not using, these highly advanced techniques. So for the breast reconstruction surgeon, they're like, wait a minute, you can't take away this code from me. These surgeries take 8, 10, 12 hours to do. And now you're only going to pay me a fraction of what this procedure deserves. So this information was broadcasted, social media platforms, that, this S code is going to go away. And what ultimately, from a strictly economic standpoint, what it was going to create is that this procedure was no longer going to be offered for breast cancer patients.
Wow.
And this procedure, the difference in terms of outcomes between the old tram flap procedure and the new DIEP flap procedure is night and day. This is not up for debate. This has been studied in hundreds of clinical studies that show that the DIEP flap is far better than the old tram flap. So there's no question that the DIEP flap was better. So now you're saying that the DIEP flap is no longer going to be paid for, essentially. And so what are these patients going to do?
Yeah.
So there was a lot of patient advocacy groups that went to Washington and said, you can't do this. This is going to limit access to this very needed type of procedure. And CMS in 2022 said, at the end of 2024, we're going to shut down the S code. We're going to eliminate essentially the access to this very needed procedure to women in America.
Wow.
And that was something that patient advocacy groups actually were very influential in saying, no, we can't do this. And they sort of backtracked. CMS backtracked and said, okay, on second thought, let's just go ahead and kick the can down the road the way that normally government does things. Let's kick the can down the road. Let's just go ahead and put a pause on this elimination of the S code, but we're going to tackle it later on. But right now we're just going to look the other way. We're going to continue doing business as usual, but it's going to be an issue in the future. How close? I have no idea, but it's going to be an issue in the future regarding access to these kinds of procedures very soon.
Well, and it sounds like, and this is just layman's terms, me listening to someone that's highly specialized in their field, but when I think about the outcomes between the first procedure that was built upon, where you extracted muscle in the lower abdomen, and the potential outcomes from that, and the level of complexity with that being obviously a lot less. And then you have on the other side of it, where you are taking the maybe fat tissue in the lower abdomen and doing the very specialized reconstructive surgery, which takes longer, obviously, with better outcomes, maybe being able to keep core strength and some other issues that are potentially eliminated. Seems to me like that's just basic advancement of medicine. Breast cancer has a massive impact across the country. Women are constantly diagnosed. I know just within Crestmont, we serve 180 families. I know of 2 in the last year that have had the double mastectomy. So it's a huge issue. And just thinking about the things you told me just in coffee maybe a month ago about not just the physiological response to this more advanced surgery being so important, but also the mental aspect to being able to do reconstructive surgery and how important that is. So it is odd to me that this would even be debatable in terms of assigning a yesteryear procedure code and payment to a current method, which has better outcomes. That's bizarre to me.
Yeah, I'm still, scratching my head. So hopefully those issues will be resolved. But, to discuss a little further about not only the physical aspect, but the emotional toll that breast cancer and the treatments associated with that take on the individual patient, families, marriages. There is a 2009 study that was done specifically to look at divorce rate among women with cancer. And it's 21% of women with cancer, not necessarily breast cancer, but any kind of cancer, go through a divorce.
Wow.
Why that is? The diagnosis, the stress of the diagnosis, in particularly breast cancer, the physical and emotional aspects associated with that. It's a very feminine part of the body, obviously. There's a lot of emotional issues that are conjured up with that diagnosis. Women with breast cancer are 6 times more likely to get divorced or separate compared to women without breast cancer.
Incredible.
So hugely important when it comes to being able to provide normalcy in that very, very trying time of a woman's life. My practice is all about a holistic approach from an emotional support standpoint, really promoting support groups for women dealing with this issue. Obviously, the surgical side of it, providing information as much as possible. Education is very important. So yeah, we're very invested in the holistic approach to dealing with breast cancer as much as possible in our practice. It's again, super important issue. It's an issue that's not going away. It's an issue that is actually getting worse, as Sam kind of alluded to earlier. So the median age of breast cancer diagnosis in the U.S. is about 62 years old, but there is a higher and higher number of patients being diagnosed with breast cancer at a younger and younger age. Why that is, nobody knows. Is it an environmental issue? Is it a lifestyle issue? I know there's associations between smoking, drinking, obesity is associated with higher incidence of breast cancer. So it's multifactorial, but the fact is that younger and younger women are becoming affected by breast cancer, and we need to address that population as well. There's other components that are being teased out slowly. The genetic side of breast cancer is becoming more knowledgeable. We're learning more and more things about it. There's a set of breast cancer genes called BRCA1 and 2. That's the one that Angelina Jolie had. So she, a couple of years ago, very publicly went through a double mastectomy and reconstruction. And there was actually a very significant uptick in women that were getting mammograms after Angelina Jolie. And it was, everybody calls it the Angelina Jolie effect, that a lot of women went on to get mammograms and found to have occult breast cancers in their body. They had mastectomy or treatments, reconstruction and that sort of thing. So we're becoming more and more aware that this is a very big problem that we need to try to get in front of as quickly as possible.
Wow. I have learned a ton, and I know that our listeners very much greatly appreciate you coming on and sharing even just a fraction of your knowledge today. We talked a little bit about the insurance side of things and the problem in the industry with breast cancer reconstructive surgery seems like it's unsolved. So I am very proud of having you on here to illustrate that, and we will broadcast that far and wide. Secondly, we talked a little bit about the mental health aspect and the divorce rates related to breast cancer diagnosis. And then just a bit about your passion for this subject. It's obvious that you take this very seriously and something that you are an advocate for women and for early detection and treatment options. And I think we need more Dr. Ochoas out there. So if you're listening to this and you're going through general surgery and you're considering this route, I hope this has helped you. If you're listening and maybe you're considering getting a mammogram, please go get one. Dr. Ochoa, what would you say is the best piece of advice you would leave with the women listening right now on early detection? What is kind of a good regimen?
Well, there's different societies that recommend different ages to start breast cancer screening for the average woman. Now, what does average mean? That means usually somebody who doesn't have a history of breast cancer, doesn't have a family history of breast cancer. Usually they're anywhere between 40 to 50 years of age. Annual mammograms are recommended, and different societies, like I said, recommend different things, different ages. Certainly, self breast exam is something that can be very easily done, even, starting at a young age. And, if something does come up, there are options regarding the treatment for the breast cancer, as well as if reconstruction or if a mastectomy is recommended. Surprisingly, not a lot of patients know that breast reconstruction is, number one, available, and number two, covered by insurance. It's covered by insurance. In 1998, there was a law that came into effect called the Women's Health and Cancer Rights Act in 1998 that basically said insurance companies are mandated to cover breast reconstruction if a mastectomy is done. Not only on the affected side, but also on the other side. If there's something that needs to be done to try to match things as closely as possible, whether it's a breast lift, a breast reduction, the symmetry procedure is what we call it, that is also covered by insurance. So surprisingly, not a lot of people understand or know this.
I did not know that till you just said that. Yeah. And somebody listening right now may be taking the radiation route, just thinking that it's an elective surgery for reconstruction, but insurance covers it.
Right. It's interesting because people that you would normally think are very knowledgeable and well-informed actually don't know this little tidbit of information, which is extremely important.
Sure.
So that's one thing to consider, is that this is all insurance covered. And other things regarding early detection, I just recently was made aware there's clinical trials going on right now on a blood test, basically drawing blood, and are able to detect stage 0 and stage 1 breast cancer at a very high sensitivity and specificity rate just with a blood test that can be started whenever. And this is probably going to create an algorithm for women and women's health that will allow early detection to be much more of a common thing. But again, early clinical trials, it's actually being used in Europe and Canada already. But, the FDA is, in America, they tend to want to see more data, more studies to verify the validity of this test. But it's coming down the pike. Hopefully in the next 5 years or so, it'll be a common thing now, just to draw blood to detect breast cancer.
That's incredible. And Dr. Ochoa, you may not have known this. I don't know if we talked about this, but the first job that I had, professional life in graduate school, I was actually a contract and finance negotiator for MD Anderson for clinical trials. So I got to see exactly, how long those phase 1, phase 2 trials took, and all the different aspects to it, and how long it takes, and how much data you need in order to get something to the finish line. And I would wholeheartedly agree with Dr. Ochoa. The FDA, it takes a lot of data, a lot of time, and a lot of efforts by a lot of private and public to get something down the pike. And that is very encouraging to hear that a blood test is in clinical trial. I hope that works out. That would be incredible. Well, I think that's all we have time for today. Thank you so much, Dr. Ochoa, for coming on the show. And it has been a pleasure. Before we go, share maybe just something, one of your hobbies, just for our listeners, something that you like to do in your spare time, outside of breast reconstructive surgery.
Well, as Sam is very well aware, passion for classic cars. Always have my eyes peeled for a nice classic car rolling down the street. It's just kind of one of the things I really enjoy.
Awesome. This is Sam McGee with the Ascent, brought to you by Crestmont Private Wealth. Today we've been talking with Dr. Oscar Ochoa from PRMA here in San Antonio, a breast reconstructive surgeon for breast cancer. And it's been a pleasure. Thank you for coming on.
Thanks, Sam. Appreciate it.
And if you found this show to be helpful today, we would love to hear from you. Reach out to me at info@crestmontpw.com. We hope you have a great rest of the week. God bless.